So in critical care paramedic, we have vascular access devices, kind of a fancy word. You're going to see there's multiple different names, central lines, central venous lines, and vascular access devices. So we're going to kind of go through the PowerPoint. After the PowerPoint, we're going to give you guys a little bit of a break, and then we're going to do some hands-on. One part of our hands-on is going to be actually accessing the central line devices. Half of the group will just do a little quiz, and it's more of a sheet for you guys to take home to remember the important information, and all the answers are on a learning board that I did. So I passed out the PowerPoint and a piece of paper for you guys. If you want it, that's great. If you don't want it, you can always leave it up here at the end. I know it probably gets pretty thick in the amount of handouts you guys get. So these objectives, I'm going to go by the first two because those are my objectives. I want you guys to understand the critical care paramedic objectives, and I like to go through these because different departments, sometimes they say, we're never going to access these devices. Why do I need to know this? Well, it's because it's critical care paramedic and it's part of the curriculum, so we want to make sure that we cover that for those that are going to be accessing these devices on a regular basis. And many of our paramedic departments in Waukesha County, our medical directors do have a protocol written in a guideline for accessing these. So we do access them quite a bit out in our area if we need to. So understand and compare the various catheters for vascular access. Why do they get put in? Why do these people have them? Indications for use, the advantages, disadvantages, and potential complications. The complications are interesting. Sometimes they'll say, well, they get put in the hospital, what do we care? Well, what if that patient, I mean, they don't stay overnight after a central line insertion. If they go home and they have an air embolism, if they have a thrombus, as critical care paramedics, we need to know those signs and symptoms. So when they tell us, hey, I had the central line put in today, I'm really short of breath, the patient's diaphoretic, tachycardic, we can kind of put those two things together that, okay, they just had this procedure done, we need to start thinking that maybe they have an air embolism or a thrombus, something going on, or is it totally separate from that procedure? Justify the rationale for central versus peripheral access. That will help in how we access these devices. If it's a central line access, we should be using aseptic technique the best that we can on our ambulances, and make sure that we have special equipment for central line access versus the peripheral access, which are our normal IVs that we start on the ambulance for the patients. Rationale for fluid and blood product administration. It's nice to know what can go through these lines, what rates can go through. As critical care paramedics, you are not starting blood transfusions in the field. However, it is in the curriculum, if it's approved by your medical director, to monitor en route to the hospital blood products. So that is something as critical care paramedics you may find yourself doing along with a lot of different medications. And as critical care paramedics, we want to know that, because to say, oh, if that hospital has it, they have the drip started, it's not my problem. It's our problem and it's our concern. If we're taking over care of that patient, we need to know all the medications, why they're infusing, the blood products, how long, why they're getting, because in our care, we're responsible to know all of that until we get that patient to the next facility. Describe basic techniques in using vascular access devices. So we're going to look at multi-lumen catheters, line placements. We're going to do the demonstration later on accessing those devices. Maintenance and troubleshooting. Not all central lines in the field you're going to be able to access with no problems. There might be a little bit of troubleshooting that we have to do, and sometimes we may not be able to access them. We may need to go back to our peripheral access, or if we can't get that, our interosseous access. So those are the objectives for the critical care paramedic. For the vascular access device, there's a couple different definitions, and I always like to start with what is a vascular access device? What does it mean? So the definitions, a couple of them, I'll let you guys read the couple definitions that I grabbed. I kind of like the second and third one. The long, fine catheter introduced in a large vein into the superior vena cava. The superior vena cava is where we want our central lines to be sitting. If they're down too low because they've been pulled out or they just couldn't advance that catheter, those are going to be peripheral. And if they go in too far, obviously the heart doesn't like when little things are hitting up against in the right atrium or the septum, so that could cause a problem too. For administration of parenteral fluids, medications, or for measurement of central venous pressure, when they say CVP, and you guys might have seen that in the ICU if you've already gone to your ICU experiences, or when you guys go, definitely look at the different waveforms that they have, because those are off of central lines, the central venous pressures, and they could have a couple different pressures that we'll talk about. So basic definitions of what those devices are. And of course, we can't call anything one thing. So when they tell us NSAIDs, we know that's a group of medications, and there's a bunch of medications that are in there. Just like that, this is kind of an umbrella term, the vascular access devices. They may be called arterial lines and ART line, central venous line, central venous catheter, or central venous access device. All of them, it's just like calling myself Heather, mom, instructor, multiple different things. So why do people get these lines placed? What is the indication in the hospital environment for them to be placed? They might have poor peripheral access, and they may require repeated blood draws. So in the ICU, you might see some patients that get a PICC line placed because they know they're going to be in the ICU or the hospital for a week or so. They're going to have to draw labs, every 4 hours. Or they came in the emergency department, they couldn't get peripheral access, or they knew they were going to have to run in a lot of fluids, and they went ahead and started a central line there. Medication administration, if patients need antibiotics, that's not always done in the hospital environment anymore. Some people actually go home with IV antibiotics, and that's something in the field that paramedics and critical care paramedics may see in the field, that a patient has to be on, vancomycin for a month, and they're going to get that medication and administer it to themselves at home via their central line. Irritating infusions, potassium has to be run very slow, for example, through a peripheral line. It burns, it's irritating to the veins. You might have had it before. So if we have to run it a little bit faster because the patient's pretty sick, it has to go through a central line. Even our dopamine in the field, they do not like running that in a peripheral line in the hospital. They really like to transfer that device, any of those vasopressors, over into a central line if they're able to. Chemotherapy, patients get chemotherapy, so we'll talk about med ports. They may get a device put in that can be accessed each time they come in for chemotherapy, but then kind of is hidden when they're done with that chemotherapy. I added cardiac medications because for the paramedic services and critical care paramedic, there's some patients coming out of St. Luke's and I believe Frederick Hospital that are on cardiac medications, and you're going to see they have an own little pump, and it may be going through a central line. Those patients need that to be able to sustain an adequate blood pressure or perfusion. So that might be a reason that we see that in the field. Those medications we're not touching, we're not messing with. We would take them to the hospital and we let the hospital deal with those. Intravenous hydration or feeding. Various populations have central lines. When we think about anorexia, those are some of the patients that may need the intravenous hydration or feeding. Sometimes in long-term care facilities, the patient doesn't want just hospice care. They would like to sustain life, and they may need that by having intravenous fluids or intravenous feeding. Seriously ill and injured patients, patient comes in, let's say you get them in the field and they have a heart block, okay? Internal pacemaker is not put in right away, okay? They put transvenous pacing. You guys may see those in the ICU when you go in. That's part of a central line that may be put in the cath lab in the groin, and they are able to do transvenous pacing through the central line catheter, but then we can also use that to give our fluids. So that's like a multi-purpose type of catheter. Dialysis, it's best for people to get an AV fistula. A little bit more secure. However, while their AV fistula is forming, they may need to have dialysis during that time, that they may do it through a central line. So we'll talk about those. Blood product administration might be another reason. If you think about patients that have really severe, like sickle cell, that require blood transfusions on a regular basis, they might end up with a central line. Bone marrow transplants. And then again, the hemodynamic monitoring, that's more in the ICU environment and in the emergency department, where they may put in a central line. For our central venous pressure monitoring, blood pressure monitoring would be more of the ART line, but the left atrial and right atrial, you can get pressure monitors monitoring out of those also, and that might be a reason that they have their lines in. So advantages and disadvantages of the central line device. The advantage is we can give lots of fluids at a higher rate. We can cause less irritation to the smaller veins that some of the peripheral devices might be in. Less scarring. We have long-term access. Increased comfort. They don't have to have so many needle pokes for blood draws. Reduced anxiety. Sometimes people are very fearful of getting blood draws done or IV started. So if they can be, possibly sedated for a central line, that's not always the case, but they might do that, and then they don't have to worry about that anxiety of going in for blood draws all the time. And it can be used for many different things: fluids, feedings, blood products, many different things. The disadvantage is any procedure that we do in the hospital or in the field as paramedics, there can be complications. Insertion, we'll talk about some of the complications. The management, if they don't have skilled providers accessing their devices, we can break their line. We can cause a thrombus to break off. So it's very important as critical care paramedics in the field, if you're able to access these. We know that there's a lot of skills that are high-risk skills, but we don't use them very often. It's important for us to stay up to par on what's best practice for those procedures. It is an invasive procedure, so invasive procedures, there's always risks associated with that, including infection. Cosmetic problems, maybe for adults it may not be as dramatic to have a port put in or a PICC line, but I worked at Children's Hospital for 4 years in the cardiac ICU there. There's lots of children that end up with PICC lines, and sometimes they have to go home with them, and that's not the coolest thing to have, as maybe a toddler is not going to mind that it's there because they get used to it, but if you're a teenager and you go home with a central line or a PICC line, cosmetic problems becomes a big thing. And expense is also another disadvantage. So when we talk about placement, in the hospital, when they place these lines, you can get a pneumothorax, okay? Many times they're looking at the subclavian vein. So of course our subclavian vein is right above the lungs there, so they do have that risk that they could end up with a pneumothorax. Thrombosis could be, and that could be an insertion or accessing. You could have a phlebitis that starts, just like some of the same things when we do a peripheral IV. Those same risks are associated with central line placement too. Hematoma formation at the site. Nerve damage. In the body, many times there's the artery, the vein, nerves are all very close to each other, so that's a potential complication of placement. Infections is a big one, and we're going to talk about that on another screen. Migration, this is a picture. Where do you think that central line is in that patient? It's in it migrated out, so it can migrate into the lung upon placement, or it can migrate further into the heart where we don't want it. When it's being accessed, whether it's in the hospital or pre-hospital by the critical care paramedics, worry about air embolism. Okay? This is central circulation, so it's very important for us to be paying attention to make sure all of our air are out of our syringes before we access those devices. Thrombus, it's a tube that's in the body that's foreign. The body is not always going to like that, and there could be a thrombus that forms either at the end of it, within, or around the tip. Infiltration and inflammation. Just like everything else, if that device comes out of central circulation or it comes out of that vein, let's use a subclavian, for instance. If it comes out of the subclavian vein, where are we infusing all the solutions? Into the chest, right? Obviously not a good thing, but by assessing the site, we would hopefully be able to figure that out. Hemorrhage. The biggest one with the hemorrhage are the dialysis catheters. The dialysis catheters, when I pass them around, they're very big compared to the rest of the devices, so if they break, hemorrhage could be definitely a concern to us, or if we're not comfortable knowing how to clamp the devices to make sure blood doesn't come out, that could be a concern for hemorrhage. Catheter damage and occlusion, we want to make sure that we're accessing them correctly so we don't damage or occlude, because for dialysis patients, this is their lifeline. Without that, they are unable to get dialysis. So. And then infections, central line and sepsis, those are huge things. And I believe as a nurse and paramedic, a really big subject that I wish we would preach more pre-hospital to our EMS providers about infections and accessing using really good technique, because we don't do any good if we save a patient's life if they die a week later from a central line infection or any other procedures that we're doing, because it's quick and in the moment. It gave that person another week, but if we would have taken our time and maybe had the knowledge, we could prevent a lot of these infections that are occurring. In a central line, many times you do have medications like vasopressor medications infusing through them, or potassium solutions, so they can be very necrotic to the tissue if that's not noted. Absolutely, and that's why we're going to go through the steps on how to access it to know that you have a patent central line, and how to do a site assessment. So if something's not making sense, you address that at the hospital. If you're picking up for an interfacility transport with the staff before you leave and you document, or if we're in the field picking up a patient from their home and we notice something isn't right with the site, that we would not use that, we would not access that and then document so they can look at that at the hospital. All right, so central line infections. It is a little bit of a soapbox of mine, but there's a lot of central line infections that could be very preventable if staff that is accessing them would just, I think, take a little bit more time. And sometimes it's just knowledge. We don't know what we don't know, so if we know it's a big deal, it's good to educate on them. So central line infections, they may be called central line associated bloodstream infections, central access bloodstream infections, or catheter-related bloodstream infections. Each facility might have their little wording on it, or education that you get from your medical directors might have a little bit of a different thing of what they call it, but it's a huge thing and it takes up a lot of healthcare dollars. So anything that we can do to prevent wasting healthcare dollars, I think, is a good thing. The Staph aureus is the big microorganism that's responsible for many of those central line infections. Statistics, these are a little bit old, but from 2011, 80,000 infections in ICUs yearly. So the patient came into the hospital, and central line infections are not that the patient had, sepsis before. This is that within about 48 hours of that central line being placed, or after being removed, that this patient ended up with an infection, and there's not a cause elsewhere in the body. So it's exclusively the central line infection. It's either a break and sterile technique when these were put in, or a break and aseptic technique when healthcare providers were accessing those devices. And sometimes it can be the patients too. 250,000 estimated annually, and up to a 25% mortality rate. So I mean, just on a central line placement. The infections increase morbidity and mortality, hospitalization stay, and healthcare costs. So to treat these central line infections, it's about $35,000 per infection. That price is probably higher. However, this reimbursement pay for performance, many insurance companies have said, okay, the patients are going to go in the hospital. However, if you cause a central line infection, we're not paying for it. So that healthcare facility eats the cost. And in the long run, it affects all of us in healthcare. I mean, everybody knows the healthcare dollars go up. It's going to affect all of us, all of our insurance. And this one I got just off of ICUs, but overall, they're, throughout the United States, the numbers are extreme. And they're not going to get reimbursed for it. What we should be concerned about most of all is being advocates for the patient and treating them just like one of our beloved family members. And we don't want them to get an infection. Try to treat our patients the same way when we're accessing these devices and caring for these devices. And this would be a benefit that they don't get a central line infection that's going to increase the healthcare cost. It's been a national patient safety goal. I know pre-hospital we don't always hear about that, but in the hospital, these are big things. The national patient safety goals, many of the facilities for accreditation follow these national patient safety goals, and medication errors is a big one, fall prevention, but central line infections is usually always high on the list too, to find ways to prevent them. I put this slide on this up here for no prep 5, 10, and 15 seconds. Because I think some of us have had students or you've trained paramedics in the field, and this is my biggest pet peeve in clinical, especially on experienced providers. Hint, hint, when you guys have clinical with me, is when we're pushing a medication through a line, and this is how we scrub it. We have our hub here, and we have our alcohol wipe, and we're like, okay, that's good. We probably didn't do much on that, and this shows you when they're culturing the tip of one of these, that at no prep, you can see that glowing, that's all microbes on there. 5-second prep, we have some of the microbes off, but there's still a fair amount on there, the 10 seconds and the 15 seconds. So it's very important for us to scrub the hub with meaning for that 15 seconds and then that alcohol on there to dry. Okay. It's supposed to be our secret. And when we're setting up new lines, you know, that's something to consider. We know if our lines that we have set up are nice and clean and sterile, but when we go into a facility or we pick a patient up, we don't know if there's been alcohol caps on those. We don't know if they've been laying in the bed or where they have been versus us taking something out of the package for the first time. So what can we do to prevent the infections? We know that infections are a huge thing. We want to do what's in the best interest of our patient and be a patient advocate. So hand hygiene is the biggest thing. Hand washing, we know we don't have sinks in the back of our ambulances, okay? What I would suggest for that is if we have a patient that we need to access their central line, we've had our gloves on probably since we started the call. We've touched everything in the ambulance, we've touched a patient, we've touched things in their house into the back of the ambulance. To take our gloves off, to use whatever hand sanitizer that you have in the back of the ambulance, let that dry, and that's when we're going to go ahead and put on our new gloves. And for accessing the central lines, the ambulances should have, excuse me, the sterile gloves, and we'll practice that a little bit later. The central venous line dressing integrity, what does the dressing look like? Okay? If we're taking them from home, you know, we may not, they may not have anybody there to do their central line dressing. However, if you're doing a critical care transport and that dressing is not occlusive and look right, they really need to change it at the facility before you transport that patient. Nurses are also taught in the hospital, if you're dressing, we don't put more dressings on top, we don't put more tape on top, we do a central line dressing change. So we're looking for it to be occlusive, just like our peripheral IVs. We want our dressing to be occlusive on there. And there's two different types of dressings that I know of. There may be more, but I'll send around this example. This is a Tegaderm CHG. It has a chlorhexidine in the middle, and that'll go right on top of the central line device. So you'll see that. Otherwise, there's that little bio patch. It's a little circular patch that some facilities may be using. I know out here in our area, they may have both still. I'll try to find the bio patch for you, but I'll send that around. So you know when picking a patient up from a facility, the central lines may have that. The PICC lines may just have the regular Tegaderm on there with a securement device. Each hospital, each facility is going to have their own policies, procedures, and guidelines on central line access, maintenance, care, and changing the dressings, but it's pretty universal that if it's not an occlusive dressing and clean, that it needs to be changed. Limit the number of line entries. In the field, this is important for us because many times we might be accessing the central line maybe to give one medication, or if they have a PICC line, maybe a pain medication. If we know we're going to be accessing that device more than once, it's better to hook up a fluid bag and just run it at a TKO or 25 mLs an hour rather than accessing the device, de-accessing it, and then 10 minutes later they need more pain medication or we need to give them an antiemetic and we're accessing it again. That's just increasing their risk for infection each time that line is accessed. And we'll practice that and talk about that a little bit. Strict aseptic technique when we're accessing the device, caps and tubing. Different facilities might have different colored caps, but these are little alcohol swab caps. And on the IV tubing, this is a patient, this is a triple lumen device. When it's not in use, there's no fluids hooked up to it. They'll put these alcohol caps on the end, and you have to kind of hold it away from. I'll let you guys practice this later. This just goes on, and that's an alcohol impregnated cap that stays on this device until it's accessed. So you may see this when you pick up a patient on the ambulance if they have, a PICC line or a central line on their chest, and we would just take that off to access that. However, this is one-time use. We can't put it back on. So it's either we need to hook up, it would be best to hook up a line to this device, or to just make sure that we're really scrubbing the hub 15 seconds with the alcohol before we access this device again. I don't know that all of our ambulance services are going to have these caps. They're in the hospitals. They're not all orange. Some of them may be green. Some of them may be orange. It'll be up to your medical directors and your departments on what kind of equipment that you guys are going to have for central line access. Those tabs or caps also go on the IV tubing. So when we have our IV tubing, we have a couple of our ports, med ports along that tubing. They also get put on there because, of course, we might access them at different times, and sometimes in the ambulance they might, lay in the bed next to the patient. The patient may touch it, it may hit something, so we want to protect all of those areas. And practices are always changing. This is what our facility, most facilities here in Waukesha County, it may change, but the more evidence-based information they get, they update the policies, and this is the caps probably, what would you say, Blake? I think probably the last 5 years we've had the alcohol caps on most facilities. Scrub the hub. So if we're using chlorhexidine, some people may have our services may have these little chlorhexidine wipes that we're used to seeing on IVs. I know some other services said, we're not buying these. We have alcohol, and that's what we're going to use. So either way, if you have alcohol, it's the 15 seconds. If it is the chlorhexidine, it's 30 seconds, depending on what device. Unless your medical director has something else in your protocol, but those are usually the adopted guidelines. The groin, the only time I would think that you would see a groin line in the femoral vein would be in the hospital. If you're doing an intrafacility transfer, those are really, really high risk for central line infections. They try to not put them in the groin area. However, sometimes you don't have any options. People may not have good subclavian veins. Maybe the doctors can't get a central line into the internal jugular vein, and the groin is what they had to work with. Those, you want to scrub a little bit longer before accessing those if we would need to en route. Less than 2 months old is iodine, the chlorhexidine. You don't want to use on pediatric patients under 2 months old, the infants. Make sure our lines are secure. Facilities differ, and many of them may suture that central line in place. Others may use different devices. So some of the PICC lines have a securement device that hopefully will hold that nicely in place. Other ones will actually suture close to where this goes into the skin and hold in there. Either way, just make sure it's nice and secure with either the stat lock, grip lock, or whatever they're using. The tubing is a big thing in the ambulance. Lots going on sometimes there. Just be cognizant when you have a central line, that's not a line that we want to get pulled or stepped on. So keep the tubing out of the way so somebody, if they pull it and they rip that suture out or they rip that stat lock out, that's going to pull that central line out, potentially. Follow policies and procedures. Everything during our lecture today and our hands-on are going to be based off of our Waukesha County protocols that we have, our best practice guidelines based off of evidence-based practice. However, we all know in fire and EMS, it's going to be based off of what our medical directors allow us to do and what policy or guidelines that they want us to follow in the field. You might have access kits. The access kits are really nice because everything you need to access your central line is in there. However, I don't know money-wise how expensive they are. Some departments might choose to order their equipment separately or have different equipment. All right, any questions on the devices, indications, anything so far? All right, so we're going to talk about the different types of vascular access devices. Peripheral could be our peripheral IVs that we put in our patients. There's also a device called a MIDLINE catheter. The times that I've seen the MIDLINE catheters, it's that they've attempted to put a PICC line in and they just can't get into the subclavian vein, either because it's so stenotic or so much plaque or the anatomy of the patient that they might have cut that PICC line and made it a MIDLINE catheter. The central catheters are the PICC lines, so it's the peripheral inserted central catheter. Many times you'll just see that PICC abbreviation. Ports. We'll talk about the med ports. There's tunneled and non-tunneled devices, and we'll talk about what's the difference between those two. These are just different names that you might hear patients describe their device. I don't think it's anything as paramedics or critical care paramedics that we have to memorize, but the Hickman, the Broviac many times is our pediatric population. They'll have the Broviac, the gross tongue, and dialysis. Many people you're going to know from their history, and the dialysis catheters just look a little bit bigger, that you should be able to identify them. The non-tunnel might be, many times are the emergency room patients that come in, they need access quickly. Those devices, they don't like to stay in very long. They assess in the hospital each day, do they need this central line, or can the central line be removed so we can, decrease the risk of infection on that patient. And that might be the internal jugular, usually a favorite spot for the ER doctors. Sometimes the subclavian, and if they can't get access anywhere else, they may go to that femoral access, but that's probably the least likely. So the MIDLINE catheter, this diagram here just kind of shows you the MIDLINE catheter is going up, but it's stopping before we go up into the superior vena cava and the right atrium. So that's still considered non-central circulation versus our central line catheters. If a PICC line, let's say we're here, that's going to go all the way up, superior vena cava, or into that right atrium. Sometimes, many times, the midline is not sutured in place. It may or may not. But if they say PICC, is it a central? My question would be, is it a central or midline catheter? Because PIC versus PICC, those are two different catheters. It's a midline versus a central line device. So it could be a single lumen, one lumen coming off, or it could be 2 lumens. I don't think we have a midline one here, but I'll show you the central line. Short-term use, usually 1 to 4 weeks approximately. There's some advantages, shorter peripheral access. The disadvantages are the complications. Not sutured in could potentially be some of the complications of the device. PICC lines. How many of you guys have seen PICC lines in the field? Many of you. Usually purple, right? Purple device in the arm. So that's inserted into a vein in the upper arm. Could be leg too, but usually we see them in the arm. And it usually rests in the superior vena cava or that right atrium area. In the hospital, IR, many times, it doesn't have to be placed there, but many times that's where it's placed. Sometimes they'll place them in the ICU at the bedside. Again, that suturing is going to really depend on the facility and their protocol. Some facilities still suture them in adults. Others will just use that securement device. And it could be a single or multiple lumen. So an example of that, I'll pass these around. These are both PICC line devices. They have different securement devices, but you can see how they come off. This one doesn't have a cap. We would not like to see this because if we unclamp it, it could potentially bleed out, and it's not a very good technique. We would be really worried about somebody having an infection. So they should always have some kind of caps at the end of them. But I'll pass this around so you guys can see the PICC lines. See if I have any more examples up here. There's another one here. You might hear power PICC line. Okay, the power PICCs. It'll say power PICC on it. Another example, different PICC line. You can see how long once they put them in, and you see how long the patient's arm is and how long they need it. The doctor will estimate and will cut. So it's not saying that every person is going to have this whole entire length. In there, body. Long-term use, they can have these weeks or months, and pediatric and adult patients both have these. And in my opinion, probably the most common devices that we're going to see pre-hospital on patients that may, again, the long-term antibiotics, medications at home that they may need to give themselves. And they are taught how to access them at home, some patients. Other patients, a visiting nurse would come by and access those. Again, the advantages: lower risk of complications, lower costs, ease of insertion and removal. In the healthcare, if the patient needs to have it removed, there's RNs that will have training in removing those. Less skin flora. The disadvantages: you have the placement complications like you have with everybody. Reliability for blood sampling. We'd like to say that the PICC line always gives us blood, but that's not always the case. And migration if it's not properly secured. So just checking if we're assessing a patient, assessing that site, making sure that it's secured so we don't go to pull on it and we're like, oh, it's not secured at all. It kind of pulls right out. That would not be a good thing. Again, these caps here, we would not use a needle to inject through those caps. Any questions about PICC lines? Again, I think those will probably be the most common device, and our mannequins have a med port, a PICC line, and a central line device that we'll be able to practice with all of those after. So the implanted ports have a reservoir that's implanted subcutaneously underneath the skin, and patient may be taken to the OR, sedated for this procedure to be done, using a large neck vein, and then they attach a port. Different names, these are not all the names, they might have many different names, but med port, infusiport, power port is a common one that I hear. They can be a single reservoir, or you can have a double reservoir. Okay, and we'll kind of later feel what the difference is between if you're touching a single versus a double reservoir, and that's where we're going to access. There's a specific needle that's used to access MedPort devices. The nice thing is long-term therapy. So you patients that may have chemotherapy or need long-term treatment. In a clinical, we had a child at Children's that had a blood disorder that he needed medication every day at home. Mom accesses his MedPort, gives him that medication, and then de-accesses that MedPort. So that might be used for that. Pediatric and adult, over 6 months old, those are put in. You can see underneath, either on the right side here or on the left side, it usually is in this area. You can see the advantages and disadvantages. You don't have to worry about water, you know. So for pediatric patients or adult patients that really like swimming, obviously an advantage to them that they don't have to worry about a central line when they're in the bath or shower or swimming. Safe and effective for long-term therapy. It's easy to maintain, relatively few complications. Disadvantages, it is a surgical procedure to have that placed. Placement complications is for all of ours. Skin punctured with a special needle. It's called a Huber needle. So on the ambulance, we have to have this needle or the PowerPort needle to access these devices. So if that's something on the ambulance services that you guys are going to be doing, we have to have this equipment. The power ports that patients have placed are nice because they can go to CAT scan and have contrast injected through them, whereas some of the older ports, they don't have them, don't have that ability to go and have that. The contrast is given under pressure. And this shows you the reservoir underneath the skin there. In the middle of that area on the med port, kind of a soft spot, and that's where we would want our catheter to go in. I'm just going to grab a couple of these to pass around. I think we only have the double. I don't think we have one of the power ports. Obviously, it's hard to get an example of these, but most of the time you'll have the single one underneath the skin. You won't see anything externally. You'll just be able to feel the little bump. These are circular ones. There are the power ports that are more triangular in shape that you can see up here that you'll feel underneath the skin. And when we go through the practical hands-on portion, you'll be able to feel the 3 grooves on the outside, and we're going to be shooting for the middle to get through, puncture through with our Huber needle. There's central line catheters. We have the tunneled and the non-tunneled catheters that we talked about a little bit. These catheters, if they're going here, and then tunneled, it's actually going to be tunneled underneath the skin. So you can see in a quick emergent, if a doctor just wants to get central line access, the non-tunneled catheters are usually the ones that are used. And chances are patients that have these central lines many times may be immunocompromised. And this is the non-tunneled catheter in the emergency room. If you've done clinicals there, those are many times they go for the IJ, and they'll sit here going into the ICU or on your ICU clinicals, look and see if they have one in the neck. However, it could be arm here too. When we're accessing central lines, we're going to make sure they're unclamped, and the first thing we're going to do is pull back, because we don't want to push any air into the device, and if there's any in there, we want to pull back. So we pull back and we want to look for blood flow. That should indicate to us that brisk response that we're in the vein and that central line is in the vein. So on the chest x-ray in the hospital, if a central line has been placed and you're, as the critical care paramedic, going to pick that patient up, I know it's something that you think, oh, that's the nurse's responsibility, that's the doctor's responsibility. You want to know if you're going to have a problem en route transferring this patient to another hospital. So you want to make sure that they've had an x-ray and that the doctor has looked at that x-ray to make sure that the line tip, the tip of that catheter is in the correct place, and also to make sure that the doctor has assessed to make sure that he doesn't see a pneumo on the chest x-ray. All right, so these are the couple of names, remember, of the central line catheters, again, placed in the OR or IR. A cuff secures the device and it acts as a barrier, so they have like impregnate it with antibiotics to help prevent infection. And the same thing can be single or multiple lumens, and it could be in adult and pediatric patients that we might see those devices in. And that's kind of hanging out of the chest there is what we'll see on our patients. So more comfortable, a little bit more discreet. It's one of the long-term use catheters, home use for the adults and the peds. Again, surgical procedure. But that might be what you see. This is that little blue disc that we were talking about before, and that's kind of hanging out of the dressing, but the main portion is covered with a dressing here. So these all look like very nice site assessments. The Grossong, another type of device. Again, comfortable, discreet, long-term use. May or may not be clamped. Most of the central line devices pre-hospital, we're going to see that they're clamped. That device will be clamped on there. We'll have to unclamp them when we're ready to access them. This is one of the devices that may not be clamped. Dialysis catheters, I would say we're going to see these a fair amount of times in the field. You may have already seen them many times being on the ambulance. Usually inserted into the jugular subclavian vein. The femoral could be used, but again, I don't think we're going to see that as long-term access outside of the hospital. That might be more on your interfacility transports. Tip rests in that same area. If it's tunneled, it's called a perm cath. So you might hear a patient say, oh, it's my dialysis catheter, it's my perm catheter, it's the name that they give for it. Long-term for patients with no other sites or that AV fistula, maybe they've created it, but it's not mature enough, so the patient can't use it. They may have this device used right now. If it's non-tunneled, the Mahooker device, and I think that's probably most commonly what we hear pre-hospital is the Mahooker. Multiple lumens. This is a really big thing of why it's important for critical care paramedics and paramedics to know these different devices. This is usually only accessed in a code or pre-code situation. I always think of it, this is the patient's lifeline. Even in the hospital, they do not touch the dialysis catheter. Many times they have to call their nephrologist to get permission to access a dialysis catheter. I know in Waukesha County, we have a guideline that we would follow in a code or pre-code situation if we can't get any other access. However, I would look back to what your medical directors and what your guidelines are on the use of the dialysis catheters. I'm going to pass around one of these other catheters again with this because I just want you to see how I feel like this thing is huge compared to the other central lines for the purpose of dialysis. But if one of these comes unclamped and we don't have one of our claves down here and this cap comes off or we take it off and we forget to clamp it, chances are we're going to have a lot of blood coming out. So just to be aware to make sure they're nice and secure. So the advantage is many times no maturity time, multiple sites are available, no venipunctures for the AV fistula. They have to access and it's with a needle. With this device they don't have that. Long-term use, ease of placement and replacement. Disadvantages, those insertion complications, lower blood flow rate, so they may need to go to dialysis longer, might be one of the disadvantages for those patients. And again, pediatric and adult patients. We don't always think of pediatric patients of needing dialysis, but you know, Children's Hospital, that's kind of an everyday thing there for many other patients. We talked about the different type of dialysis and the access. The grafts created when veins are too small to develop into a fistula. So they have to put a synthetic tube or a graft under the skin, and that graft becomes an artificial vein used for dialysis. Again, usually not accessed by us pre-hospital. Okay? When we talk about the AV fistula, when an artery and a vein tunnel together, either we're creating that or it inadvertently happens, that's when a fistula is formed. So for dialysis, they create that communication between that artery and that vein. And because you have that artery, our blood pressure, under pressure, that's going to help increase the blood flow into the vein, and that vein grows larger. So many times when we look at a patient's arm that has a fistula in their arm, we see that it's very large, and that's how it grows, and at a certain point is when the doctor allows them to be able to use that if it's matured for dialysis. Again, usually not accessed by us. Peritoneal dialysis catheter, you might see some patients at home that do their own dialysis. And we don't access that, but you may see that hanging from their abdominal area, and we don't access that catheter. The Mahooker and the perm caths, again, we talked about those. Those would be the devices that may be hanging from their chest here, and usually only accessed in the code and pre-code situations per your medical director or department policy. The non-tunneled central vascular access devices, remember, are usually these smaller ones where they're not too long. The internal jugular, subclavian, femoral vein. When they talk about arrow or cook, if you've seen in clinicals in the emergency room a central line being placed, it's usually just what the hospital is using. So if they say, it's an arrow or cook on top of a central line box, it's just the name of the device. Okay. Can be placed at the bedside, emergency department, ICU, wherever they need it. Sutured in place. There's no cuff that's holding that underneath the skin. No antibiotic impregnated underneath the skin. So that's why it's important to have that tegaderm dressing with the chlorhexidine impregnated in it, or having that bio patch around that device, the insertion point. It can be up to 5 lumens. So if they may need blood, may need vasopressors, may need fluids, they could hook those all up. Therapeutic hypothermia, if they're doing that protocol in the hospital, it's nice to have a couple different access lines, one for your cooling fluid there. Short-term access, our pediatric adult, both of our patients. So you see one in the neck here. That's when we'll use the chest there, that's subclavian. And then here is the femoral, the least favorable site to put a central line in because of the risk of infection. But again, pre-hospital, but some of you are also going to do interfacility transport, so you might see all of the devices. So the non-tunnel, the advantages, easy to insert, especially if the doctors have the ultrasound, that they're able to ultrasound that area and be able to see where the vein and the artery is. Trained personnel at bedside, multiple lumens, nurses can remove those. The disadvantages, insertion, short-term use. The infection risk, obviously, is a big concern, especially when we're rushing to get that in. And this is not used at home. Patients don't go home with these devices, typically. I've learned in EMS, never say never. Usually these are assessed daily to see if they can come out, get them out as quickly as they can. Again, all of those sites look really nice. The dressings are clean, they're intact. The sites look good, there's not redness. There's caps on them, we like that. All right, so assessment. We are either have our patient pre-hospital that we really need to access their device, or we're doing an interfacility transport and we want to make sure that we have a good patent central line before we leave. So the first, determine, is it a peripheral IV that they have? The external jugular, obviously paramedics on the department, some can place those. IO placement versus using an existing VAD, vascular access device. And it's going to be based off your protocols. It's going to be based on your comfort level if the device is working. If the device doesn't work, that's easy for us. We're going to have to figure out different access, whether that be our intraosseous access. If we can get, excuse me, a peripheral, that would be very nice. Or paramedic level, you may have to start thinking about an external jugular access on the patient. Obtain the line information. Patients and the family members should be able to give us the information. They get education before they go home. Or if they're, I don't know, they should have some kind of a sticker or something that can tell us what kind of device that is. Where the tip of the catheter, if we're at a facility and it was just placed, it would be nice for us to know that, yes, the doctor has seen the x-ray, he believes the tip was in the right place, and he didn't see a pneumo on the x-ray. Visually inspect. How many lumens do we have? Are they infused? Are they capped? Do they have the lure locks on them? Do they have the alcohol caps on them? Because compatibility is a huge thing, and we don't think about that all the time until you're en route to the next facility and the patient's status changes and we need to give a medication. We can't just go start infusing things in a line. What happens when you give pretty much anything with bicarbonate? What are you going to do? Not going to be compatible, right? You're going to have a problem with your line and possibly lose that line. So we need to know the medications that are infusing through that port, and are they going to be compatible? Hopefully we have one line that just has normal saline, that if we have to give any medications en route, we know that it's safe to push our saline through there. Versus if you have, dopamine running on another line, we all know it's kind of hard in the back of our ambulance to be paging through a med reference guide to see if the medications we're pushing are compatible with, our dopamine, our norepi, or whatever drip that they have running. With blood, we shouldn't be pushing anything in that line. The dressing, is it dry? Is it intact? And what does the site look like? What would we expect? Well, we want it to be free of redness. We don't want to see any inflammation or swelling in the area. We would be concerned about, infection at that site or a hematoma formation if we see inflammation. Drainage, okay? Blood should not be draining from our device. Fluid should not be coming out of our device. And pus should not, or purulent fluid should not be coming from that site. Patient shouldn't be complaining of, a severe amount of pain, bleeding, other signs and symptoms of infection or other complications. Hematoma, skin erosion, catheter damage, etc. We would want to document. Yes, the site assessment, looked like this, or if there was problems with that site assessment, make sure we document. So these are central line devices that look really good. Would you agree? Sites look pretty good. They're occlusive, they're dry, they're clean. We have caps on our devices. And there are various devices. We have an arm, a couple of chests, a neck device, and I'll tell you the neck devices and the groin ones are the hardest to keep occlusive. Okay, when you turn your neck, that dressing sometimes isn't always intact. Same thing in the groin, that dressing tends to peel up. So if it's not looking like it's, good dressing, ask them, hey, do you think you could please help us out and change the dressing before we take this patient? What do you think about these? We had some problems, right? For gauze dressings, most facilities require that if there's gauze underneath the dressing, that it has to be changed within 24 to 48 hours versus other central lines, it's like a week. I don't think we're doing central line dressing changes in the field, but just to know that a site like that, that's really not acceptable to have with that drainage that's just sitting at the site, that should probably be changed. We don't want to see the site bruised. That would be concerning to us. Those blisters, what do you think happened there? Yep, probably infiltration of some kind of irritating solution. Poor pediatric patient, the foot, central line device occurred there. All right, any questions on what our site assessment? That would be the first thing, is our observations. What do we see? Is it dry? Is it intact? What does our site look like? And make sure we document that. The next thing is our vascular access device care. If we need to flush the device in the field, we'll have to look off of our guidelines on if we are using a heparin flush or a saline. My thing is in the field, seeing as we're accessing it just to get that patient transferred or until we get to the hospital, it's just going to be saline. Okay? I can't imagine that you guys are going to be doing heparin, but I just want you to be aware in the hospital environment, they do have heparin flushes and they have saline flushes. It's going to be based off the hospital policy on what they use on the devices. So I'll pass these around. You guys obviously know what the saline flush, but just so you can see what a heparin syringe. So if you're sent with that, if the patient says, oh, I have these for you to know that if your policy guideline is to flush with the saline, you don't thank the patient for helping us and giving us that equipment or the hospital, but we should probably stick to the saline flushes. Dressings, we went over the different types of dressings and we talked about the every 7 days, the gauze every 48 hours, unless it looked like that previous one where it was saturated with blood and fluid. If it becomes soiled or that dressing is compromised, it needs to be changed. A couple things about vascular access device before we take a stretch and before you guys start doing your hands-on practice. Needle-free equipment. Pretty much everything is lure lock. It's very safe for us, patients, and that's what we should be using for the access. Med ports, obviously they need a needle to access it, so that's a little bit different. But for our connections, when we're pushing medications, needle-free equipment. Use the strict aseptic technique all the time, even in a rush. Again, if we think, nope, I got to give this epi now, instead of taking that couple extra, 15 seconds to scrub the hub the first time you're accessing it, you may save that person's life now, but we haven't really benefited them if in 2 weeks, a week from now, they die of a central line infection. Okay? Maintain a closed system. Those claves, those little blue or the clear ones, claves, blue caps. Connectors, make sure all our connections are good and tight, not too tight, but secure. Keep the line clamped until we're ready to use it. There are some exceptions. Some of those devices, like the gross hog, they may not be clamped on a regular basis. Wear a mask per your county and department protocol. The reason I say this is not all central line devices require a mask. However, in the field, paramedics may not access them enough to be comfortable all the time to say, okay, this is a dialysis catheter, this is a med port, this is a PICC line. Do I wear a mask or do I not? So when the Waukesha County protocol was updated with Dr. Schultz, it is put in there for Waukesha County to wear a mask, because in the time that you need to access a line, we don't want you thinking about, oh, what kind of device is this again? Do I need to wear a mask? Do I not? So just know that you may not have to wear a mask all the time, but today, the hands-on, we're going to be practicing that you're going to wear a mask each time you assess or access the different devices. Don't use syringes smaller than 10 mLs. You increase the pressure in the line. So for some of you guys that you relate better to fire hose, once we go in a smaller diameter fire hose, what happens to our friction? Increases, right? Same thing with central lines. The devices, if you're using a 3 cc syringe, that's going to increase the pressure. So it's pretty standard across the board to use a 10 ml syringe for access and pushing medications, so you do not increase the pressure in that line, potentially causing complications with it. And follow the department and county protocols. I tried to give a nice overview of the different devices, but it's going to come down to what our medical directors, the equipment they would like us to use, the guidelines they would like us to follow for accessing those devices. Any questions on any of this? Seems pretty. We'll practice here in a little bit. What happens if we get to the device and we're having problems? There's no blood. Okay, we'd like to pull back on central lines to make sure that we see blood, okay, to help verify for us that, okay, we know that this device is patent and that it's in the vein. Try to unclamp the line. Sometimes that seems like common sense, but when you're in an emergent situation, it's happened to me before, that I'm like, oh, I really am not getting any blood off this line. I don't have anything to waste to draw my labs, and I think, oh, Heather, unclamp the device first, and that might help you. But if you don't do it for, a year or two, and then you go to do it, that might just be a little reminder. Have our 10 ml syringe ready. Look for kinks in the device. Sometimes we're holding it and we're turning on the ambulance to do different things, and we're not noticing that it's actually kinked. So make sure we don't have any kinks. Sometimes it might help to have the patient lie flat. Sometimes if we have them cough, if the tip of that device is up against that vein, sometimes repositioning or med ports, having them put their arm over their head, just helps reposition that a little bit, that we can get that blood pulled back. Head turned away from device. Always have the patient do that when we're accessing them, because if they cough, we don't want any of those germs to go on the device. So it's good practice to always have the patient turn away from the device when we're accessing that. Roll side to side if we're really, having trouble. Sometimes this might be more, when we have time in the hospital to do versus pre-hospital. If it's not working pre-hospital and we have a critical patient, we might have to think about what other access, what are our options. Dislodgement or break, we might have this in the field too, where we're not accessing these devices, but we get on called to a dialysis patient where their line has broken, or a patient, central line, a pediatric patient that was playing or thought that it would be okay to use the scissors to cut it. It's crazy what kids think to do, hey? So we're going to try and clamp the line if we can. Try to roll that device up and clamp it. Control our hemorrhage. Lots of different devices that some ambulances in the field have. Alcohol, chlorhexidine over the hole. Occlusive dressing. Again, we don't want air to get in that line and call out an air embolism. Notify medical control. Let them know what we're coming in with so they can get the appropriate, prepare as much as they can for us, or resources they need. If there's resistance met in our catheter, we made sure the clamps are open. We still have all this resistance, then we're done. Pre-hospital, we're done. We're stopping, we're aborting the procedure, notify our med control. When we get to the facility, the receiving RN, let them know that we attempted to access the device, couldn't get blood to come back. We met resistance, couldn't flush, and we're gonna document that. And that's all, again, in the protocol, and I think it'd be even outside of Waukesha County, similar in other protocols. If we're picking up a patient that recently had a central line in place, or maybe somebody that's had that device for a while, air embolism, just nice refresher for paramedics to remember the signs and symptoms of the air embolism. So the tachycardia, chest pain, pale diaphoretic patient, jugular vein distension, cardiac-wise might be going on. Pulmonary, the patient really looks like they're having a lot of dyspnea, difficulty breathing, tachypnea, wheezing, cyanosis. That's usually a dead giveaway that something's going wrong, right? Neurologically, they might get anxious, dizzy, change in mental status. What's our treatment if we think this is going on? We want to clamp that line, place the patient on their left side, high flow O2, let our medical director know, and rapid transport. And of course, we're going to document as we work with any other procedure. Again, just a couple access reminders. Follow your department protocols or guidelines. know what devices you are or are not allowed to access. Your medical director may say, you know, we're comfortable with you accessing med ports. We're not going to access other central line devices, or you may be able to access all of them. Follow proper procedure. No fistulas, normally not accessed by EMS. Aseptic technique, aspirate, pull back, we want to see that blood. Use a 10 ml syringe, and if you meet resistance again, stop, abort, notify, and document. If there's multiple lumens, and one of them is not pulling back, it is appropriate to go ahead and try the other lumen to see if that one is patent. All right, and we are going to practice with PICLINE, the central line device, and the implantable med port. Any questions?
I noticed some were colored in the field and if were permitted to access. Is there a difference?
You know, it's going to depend on if your medical director has kind of a concrete one. In the hospital, they'll say sometimes, you know, on the red one, we'll use that for blood draws, use the other one for infusions, or they want, you know, a certain infusion in the distal port versus the medial port. In Waukesha County guidelines, we do not have that predetermined on which lumen to use. Sorry. You might ask the patient, you know, is there a normal one? The patient will know. Believe me, they know the lumens that they have problems with. We could ask them, but otherwise we don't have it in our palette or in our guideline on which lumen to use.
And they're all the same diameter?
It's going to depend on the device and the diameter. And on some of these devices, you might be able to see when we're looking at them. I'll send around some of the double lumens. You'll be able to see some of them do have, one of the lumens is a little bit bigger. So sometimes that is the one that may not get occluded, where the other one might get easily occluded. And we're not dealing with the occlusions in the field. That's something that they're going to deal with in the hospital with TPA administration or however they're, what's their policy on that. But yeah, that's a good question. We can always ask the patient the different colored lumens and which one to access. In the ICU setting, they're pretty specific. The brown one, they want the central venous pressure monitoring done on versus some of the infusions, but usually on the med ports or the different devices at home. Yep, so on our Huber needles, and I think you'll see a lot more power ports, and that's why in the ambulance these can be accessed with this, but if the patient gets to the hospital and they need a CAT scan, they'll have to do the power port one, which, I mean, we're going to use what our department has. If our department says we're not going to get the power ports, these have to be used to access the power ports, and there's a little bit of a difference in the needle size that you guys will see when we put our hands on. One's a little bit longer than the other. So when we initially are going to go in to the med port and we have it secured, this is going to go in. These butterflies then relax out. Our dressing is going to go over the top, and I'll show you how I tape. I usually put the tape underneath and then put it over so it's really secure that if somebody accidentally does pull on it, it's not going to get pulled. So the needle does just kind of sit in there, but the dressing usually holds it down nicely. Good question.